seniors and dear colleagues. We are very happy in this afternoon, Indonesian time, of course, in the morning in the Netherlands. We can join together in this event to discuss about the pituitary care. And we'd like to also thank you, Professor Biermasz, for being here with us, although virtually. Hopefully in the next meeting we can have you directly here in Jakarta, of course. And we'll be very happy because later on we can have also discussion about some different aspect in terms of pituitary care of Indonesia and the Netherlands. And we can also foster collaborations ahead as well. So without further ado, first of all, I would like to invite Professor Hegar as the chairman of the Indonesian Medical Education and Research Institute to give his opening speech. Prof. Hegar, time is yours.
Okay, thank you, Dr. Diki. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Yang saya hormati Profesor Dr. Ketut Suastika, Sp.PD-KEMD, the chairman of the Indonesian Society of Endocrinology. Also, Dr. Tri Etarigan, Sp.PD-KEMD, as a head of Division of Endocrinology, Metabolism, Diabetes, Fakulti Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital. And also Dr. Diki Altahapari, Sp.PD-KEMD, Ph.D, as the head of Metabolic Disorder, Cardiovascular and Aging Research Cluster, Indonesian Medical Education and Research Institute, IMERI FKUI. And of course, our special guest lecturer, Professor Nienke and Biermasz, and also Professor, Doctor, and all participants as well. Appreciation for MVA cluster for conducting such interesting event regularly. And also thank you very much for Professor Suastika and Dr. Julie Tarigan for the cooperation and also the support of the member for IMERI FKUI during the last 5 years. Okay. And this kind of event is of course very important for IMERI FKUI, especially for our scientists and researchers to provide their inspiration in developing research and innovations. Like this, the topic that will be discussed this afternoon. As we know that the pituitary is a pea-sized gland that is housed within a bony structure at the base of the brain, but has an important function in controlling the function of most other endocrine glands. It means that if the pituitary gland doesn't function properly, it will affect vital parts like brain, skin, energy, reproductive organ, vision, growth, even mood, and more. Having this function, making the pituitary care as a big concern for us, and many questions will arise, such as, for example, how do we know if the pituitary gland is not working? How can I improve my pituitary function? What tips for pituitary gland health? What are the symptoms of pituitary gland problem? Or how do we take care of the pituitary glands? I'm sure those questions will certainly be answered by this their scientific meeting this afternoon. And it's also hope that it will become an idea for us to create a better quality of healthcare and also quality of life through innovation in medical research and also medical education to our society. So I would like to thanks very much to our guest expert, Professor Nienke and Biermasz, not only for this afternoon, but also for the collaboration that has been established with our scientists or our researchers for MVA cluster, for especially in IMERI FKUI. So I would like to ask you to join this meeting. I think will be interesting for all us. Thank you. Please join the meeting. Thank you, Dr. Diki.
Thank you, Professor Hegar, for the very kind opening, and thank you very much for allowing this event to be able to be conducted in this afternoon. Thank you for your support from IMERI. And the next one, I would like to invite Professor Ketut Suastika as the head of the Indonesian Society of Endocrinology. Time is yours, Prof. Suastika.
Terima kasih, Dr. Diki. Om Swastiastu, Assalamualaikum, salam kebajikan, salam, nama budaya, salam sejahtera buat kita sekalian, salam sehat juga sekalian semua bersama keluarga. Selamat sore, good afternoon everybody. Yang saya hormati Prof. Hegar sebagai Chairman IMERI FKUI, kemudian Dr. TJ, ya Ketua Divisi Endokrinologi, Dr. Diki juga yang saya hormati sebagai inisiator dari pertemuan ini. Senior-senior saya ada di sini, ya Prof. Sidar, Prof. Sarwono yang saya hormati dan semua peserta. Rasanya on behalf of the Indonesian Society of Endocrinology, very happy and a great pleasure to be here in the guest lecture who have the initiative by the Dr. Diki, and then this event supported by the collaboration of IMERI FKUI and also Division of Endocrinology FKUI, RSCM, and also Indonesian Society of Endocrinology. I'm sure that this meeting is to be very important for us since pituitary organ is the complex organ and having a very complex function, and then not rarely we found the disorder of the pituitary, but in other side it's sometimes very difficult to diagnose and to treat them because we are lacking of the facilities both for diagnosis and also availability of the treatments. In this moment, I would like to express special to our guest lecturer, Professor Biermasz from the Netherlands, and I hope that your contribution, your experience will be enrich our knowledge about how to pituitary disorders should be cared well, and then and we can be used in our practice in our age hospital. Jadi lagi sekali terima kasih saya ucapkan Dr. Diki dan juga seluruh peserta. Semoga pengalaman beliau ini kita bisa manfaatkan untuk praktek sehari-hari. Once more, thank you very much, Professor Biermasz, for your contributions, dan juga untuk semuanya, ya all participants enjoy the meetings and selamat sore. Terima kasih.
Baik, terima kasih Prof. Suastika. Thank you very much, Prof. Suastika, for the very kind lecture for the opening of this session in this afternoon. So I was asked by the committee to get the group photo first before continuing to the next speaker, Dr. Trijuli. That's fine with you, Dr. TJ. We first would like to take a group picture if that allowed, just to make sure everything is still on the Zoom. Oke, Mbak Tika minta tolong ya Mbak Tika ya. So all participants, if possible, you can turn on your camera. We can have a group picture first with all the guest speakers as well as with the professors and all attendants. Mbak Tika boleh minta tolong Mbak Tika?
Ya, baik. Prof, Dokter, Bapak Ibu sekalian, saya izin screenshot. 1, 2, 3. Slide yang kedua. Dan yang ketiga. Baik.
Terima kasih. Okay, thank you very much. And now we would like to go to the next session. We would like to hear a welcoming speech from Dr. Trijuli as the head of the Endocrinology. And maybe Dr. Trijuli will also share a bit about the challenges on establishing a pituitary clinic here in Indonesia, specifically from our Cipto Mangunkusumo Hospital. Please, Dr. TJ, time is yours.
Thank you very much, Dr. Diki. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon, everybody. Dear Professor, seniors, and colleagues. On behalf of Division of Endocrinology, Metabolism, and Diabetes, warm welcome all of you, professors, seniors, and also colleagues. I would like to express my thanks to all of the Professor Hegar as chairman of IMERI, and also Professor Ketut Suastika as head of Indonesian Society of Endocrinology, and of course for our distinguished speakers, Prof. Biermasz from Netherlands, and also Dr. Diki and Professor. Thank you for the opportunity to share about the RSCM, our hospital here, Kencana Joint Pituitary Clinics. I think this Joint Pituitary Clinic just operate in 2 years. These 2 years before this clinics, we deliver the clinic or the service in the pituitary only as separate things, yeah. So maybe in our endocrine clinic and the others from pituitary neurosurgeon and the other ones. But today we collaborate with all of department, yeah, in this hospital to deliver the joint pituitary clinics. So pituitary clinics, I think today we serve some patients from all of the Indonesia, and we have been sent from the Samarinda and also from the other parts of the Indonesia, but also mostly from Jakarta. And today we held the clinic day in the week, yeah, and we also put in the social media for the patient, yeah, so they know from the social media, but also from the like Instagram, yeah, and also and the other social media. We deliver the clinic, yeah, as integrated clinic. So the patient coming, yeah, with the doctors in the same meeting. So all of the doctors team sitting together there, yeah, there, and they face to the patient with the family, and they describe the problem and give the alternative or planning, yeah, in the next future for the best practice. This is also the some of the teams, yeah, the patient. We discuss with the family, with the doctors, yeah, doctors by doctors tell to the patient. And before doing that, we meeting together, yeah, doctor's team before the patient coming. This is, I think, our one of the pituitary care in our hospital. The other problem is multidisciplinary case meeting, yeah, on the Wednesday morning, yeah. So the doctors, all the doctors, yeah, and presented by the resident or the fellow, and we discuss together with the expert from the other department. The other ones is we have also a gamma knife radiosurgery here. I think it is the only one in Indonesia. The gamma knife radiosurgery. I think it is a very sophisticated services. Yeah, not. I think yeah, only only small part of in the world having these facilities. The other one is, this is our case, yeah, macroadenoma, empty cella, prolactinoma, acro, Cushing disease, yeah. central diabetes insipidus than the other ones. So today we're struggling to the pituitary registry. I think this is the registry before, and this is the last data that we collect until 2011. Yeah. So today we try to develop the electronic registry and the more better registry, the pituitary registry, maybe from Cipto Mangunkusumo hospital first, and then we extend to the Jakarta region, and then Indonesia. So this is, I think, we call our colleague from all of the province in Indonesia to do this together. Yeah. So this is the data until 2011, I think. Yeah, we collect around 41 patients. This is the symptoms. Yeah, and then the data, and we need a better registry in the future. So we I think more collaboration to our colleague from all of Indonesia. So this is our problem in the pituitary clinics, yeah, number of patients. So I think we know that the pituitary patient is not so big, yeah. So every patient is very, very valuable for us, yeah. The data, and then lab tests. Also, some of tests is not available in our hospital, yeah. And some of facilities is not covered by government insurance, like Gamma Knife is not covered, yeah. And then the other one is delayed cases. So the cases coming to our hospital with the microadenoma, so it is hard to give the better or the best outcome for the patient, yeah. And the other one is collaboration and not networking, yeah. Some of patients we found, yeah, that only treated or managed with the surgical approach, yeah, not the comprehensive approach. So today in the joint pituitary clinic, before we plan to do something for the patient, we sitting together with the teams, and all of the aspects we discuss, and we give the best choice for the patient. I think that's all from our experience here. So we need more maybe sharing from Prof. Biermasz, the pituitary care in the Netherlands. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. TJ, for having shared the experience at Cipto Mangunkusumo Hospital. Yeah, we are currently from the Indonesian Society of Endocrinology on the guidance of Professor Suastika, also preparing now national registry on pituitary disease as well, but still on the very early stage, and hopefully we can also expand the registry, also increasing the quality of pituitary care in Indonesia. And now we will move forward to our esteemed guest speaker, Professor Nienke Biermasz. Before you give your lecture, I would like to introduce you to all the audience. Professor Nienke Biermasz is a seasoned internist endocrinologist from LUMC. He is a professor of internal medicine. She had several high-ranking positions as a board of directors members in the National Pituitary Society, as well as executive committee member, European Neuroendocrine Associations, also chair of the main thematic group of pituitary, EndoERN, European Reference Network for Rare Endocrine Conditions. And she also professor of internal medicine, in particular top referral and multidisciplinary aspect of pituitary disease and LUMC. And I heard recently you also get grant on Prolactinoma as well. Okay, we're really happy to have you here, Professor Biermasz. And now, time is yours to share your experience and knowledge.
Well, thank you so much, Dickie, for inviting me. It's really a huge honor to to be able to share experiences. And well, I think this morning I already learned something from you. So this interaction is great. We are used to do combination clinics with all multidisciplinary partners as well. And we have a hospital outpatient setting that is far less patient friendly, as I see your pictures with a round table with the patient and the family. We have a table with two sides, and on the one side it's the doctors, and on the other side it's the patients. And I think this is an improvement that I really would like to pursue after seeing these great slides. So thank you so much for that. And well, I hope I will be able to share our well, way of thinking of pituitary care. And well, I hope that there is room for interaction, because I think it's so much important that we discuss instead of that I sense. And well, I would really like to answer questions, and well, maybe there will be next time to give more well, ideas and share ideas. So I'm going to share my my screen. I hope I managed to do that. Wait. No, one moment. Share screen. Do you already see it?
No, not yet.
Now?
Yeah, I'll do. It's very good.
Okay, great. Can you see it now?
Yeah, can see it clear.
Okay, great. Thank you. Well, I would like to share some thoughts about the way we have been developing our multidisciplinary pituitary care units. And what I think it's important to know that in the Leiden University Medical Center, we are well, we are a surgical orientated center. So we do not have the gamma knife in our own hands, but we have excellent surgeons. So when we are, well, at a round table with the patient, we always try to, well, just as you had, try to find the best way of treating a patient. And I think that because of having surgery in your own hands and having gamma knife, for example, elsewhere, that makes it there is always a little bit disbalance, because you well, there's one thing you know everything, another thing you need to refer, and that makes it, well, sometimes it's more difficult that way. So I think we are excellent in balancing the drugs versus surgery. Well, probably you can confirm that, but you also would need gamma knife surgery in your own hands to really understand what is the best way of treating a patient. So that is well, something we could discuss later on. But so we are a surgical center. And so my talk will be directed to developing of this balance between medical treatment and surgical treatment, and of course radiotherapy if we need it. I have a history of well, pituitary care from my when I was a medical student, because then I started my PhD on outcome of acromegaly. And so this is more or less my journey for me of the team. In the first instance, we had a kind of a paper registry on pituitary patients. And there was a retrospective evaluation of biochemical outcomes, because that was the first data that we could provide. So in the 90s and early 2000s, etc., we reported on biochemical outcome of surgery. And then, of course, we became interested in more than biochemical outcome. So we evaluated the long-term clinical outcome. So we reported on several aspects of long-term morbidity, persisting disease, for example, in acromegaly, the joints, in Cushing's disease, the persisting cognitive problems. And I think that's very important to understand why we need to try to make the best of the initial care path of a patient, because that determines their future. And I'm not sure how it is in Indonesia, but many patients with pituitary conditions are quite young. So they really have a life ahead, and they we need to do our best to maintain the possibility that they have their career, that they have their family. And that's really a challenge, I think, because if the first step is not good, it's really a long-term issue when you can't control patients. So this long-term morbidity was very of interest of us. And when we were evaluating this clinical outcome, then in addition to the morbidity things, we also became very interested in quality of life. And quality of life is very vague, one could say, but it's also what is important to a patient. And quality of life is one aspect that you can measure with a questionnaire, but of course it's not the same as quality of life for the patient, but quality of life questionnaires are the best we have. And I think one challenge also when you think of building a registry is how we can address the view of the patients, which simple quality of life lists or symptom lists reflect how patients are doing. And that is a recent a challenge for us to find a way to make this patient relevant outcome reports as well. So we've been doing our best to develop a pituitary specific clinical questionnaire that is important to the general pituitary patients. So that's has been a research topic, etc. And we try to also to address some psychosocial management in addition to the medical care to help patients understand their disease, accept usually the delay in diagnosis. That was one problem in your country as well. Delay in diagnosis is something very important because patients have had complaints for years, and then they know what they have, but they have not incorporated it in their lives. It's important to give that some attention, and also to help them to explain why they are tired, why they can't concentrate, etc. That's a trajectory, and because there's not a lot of information, and they will not know other patients and the outside world. Sometimes, of course, when you are an acromegaly patient, you see it from outside, but if you can't see it from outside that you are a chronic patient, it's really hard for cases. So that was one way to improve long-term outcomes, so to give also some psychosocial support. But I think the main issue that we think is important to improve long-term outcome is to optimize the pituitary care trajectory from the beginning, and to be very critical at the first step that you take, and to invest a lot in a patient to help the best outcome. And ideally, we believe that curing the disease by total resection when you have a pituitary adenoma, and without pituitary function loss, is the best we can get. So that's the ultimate goal. And of course, we all know that that's not achievable by everybody, but it's always on our mind. When there is a way to achieve that, we are aiming for it. And that's a reason that we are really busy with developing our care path and our pre-operative and diagnostic planning and investigation to make it possible that, if possible, we want to total resect the tumor without side effects. So then you have to have the best surgeons that are present, or you have to have very precise gamma knife as well. That's the alternative, or you have to have very good drugs. And we're in a non-ideal world, so usually the strategies are not perfect, and then you have to to balance between the best you can get. Last 5 years we have been busy with developing our care path, and we try to develop the care path using the value-based healthcare strategy. And this strategy is important because it's, I don't know if you have heard about value-based healthcare, but it's an idea, you can see it from the economic point of view. And then it's more about the money, but you can also see it as a view from the patients. And then it's about the benefit of health, etc. So the health outcome, and then the cost you need to invest to achieve this outcome. And when you are thinking about your care path, I think it's very important in this value-based healthcare approach that you see not your own tiny parts that you are caring for the patient, but it's the full picture that is relevant to the patient. And that's also why I think in pituitary care, the multidisciplinary care is extremely important, because you're never doing it alone. It's the endocrinology is the caretaker, but you really need the eye doctor and the surgeon and the ENT doctor and the radiotherapist, etc., etc. So you're never acting alone. Well, when you want to choose the best treatment, it's very important that you have the outcome data of your own center. Ideally, of course, the outcome of the country and other centers as well, but because you have to compare what you're doing and whether it's the best you can get for the patient, or that it's it's better elsewhere, or the other alternative is better. So you're very depending on your real-time outcomes to choose for new patients. And that is what we have been trying to develop. And I think that's, I heard you say that you're searching for a registry as well, how you can organize it. And it's a really hard issue, because it's so difficult to really register what you're doing in your care. I think that's a huge challenge, and I'm not there yet with my team. We are considering how we can improve our treatment path and register the outcomes. Well, I think a very nice clinical example of what we try to achieve is, for example, in the Prolactinoma. There recently was a consensus meeting organized by the Pituitary Society. And I think one of the interesting things in Prolactinoma field is that there is idea that maybe in a very good surgical center, the tiny prolactinomas with excellent perspectives for total resection without risks, that there is a discussion and a balance between what is best for the patients, and it's either one intervention with surgery and cure afterwards, or medical treatments. And in medical treatments, of course, there is the hope that after a few years you can stop the drug. But in real practice, usually there is quite a while that patients need to continue drugs. And that's fine when there are no side effects. But if there are, progressive side effects, mild or less mild or severe, that's of course, there is somewhere a break-even point between, taking the risk of one intervention with surgery and accepting mild or, not so severe side effects of drugs if you need to continue them for longer time. And that's a very interesting thing that, of course, requires an excellent surgical setting, because you can't accept hypopituitarism in young cases for the rest of their lives. Then a period of cabergoline is probably better. But if you can, almost promise that you're not going to damage the pituitary, then there is a balance. And I don't have the data yet, but there is a discussion going on in this field. And maybe we can discuss on this later. And I'm sorry, this is my introduction slide, and I really like to tell instead of show slides. So I will move on with my presentation and discuss some of the ideas. And I come back on the thoughts that I have already given. So this value-based healthcare, it can be about economics, but you can also use it for patient value. So then you try for each step that you take in the care path and for each intervention that you want to do, you are thinking of what does it help the patient or not? And of course, for pituitary care, we know that patients at the moment of their active disease, they usually have impaired quality of life. But sometimes they have no complaints at all. And then it's important to explain why you should treat, because of course, in the long run, hormone overproduction has its consequences. And I hope you can see my slides, but I was telling again about outcome. And I think this is very important for your registry thinking. That if you want to consider outcomes, the value-based healthcare approach considers 3 tiers. And the original model is from Porter in US. It's the health economics, but we try to make it more pituitary specific. And then, of course, survival is usually not an issue in pituitary care, but it's always important to realize that it's one of the most important things that we have it safe. And then, of course, the first thing you want to achieve is endocrine remission and visual recovery, and if possible, recovery of pituitary function, which is sometimes something that you can achieve by surgery. Sometimes you want to balance between choosing for total resection or partial resection. And we try in the preoperative clinic, we really try to discuss the approach of surgery. And that's one of the things I learned from doing a lot of combination consultation, that it's not, I send the patient to surgery, but it's really thinking together with the surgeon what is the best for this case and whether they need to aim for total surgery or debulking, etc., etc. We also put in a highest hierarchy the recovery of quality of life. And that's, of course, difficult because if you treat Cushing's disease, it's interesting, but usually they don't feel good after surgery. And so it's important to realize that that's the case and to explain why we need to act and change quality of life. Then, of course, if you move on with discussing outcomes, it's about the timing and the time to recover. And that's of course important when you are discussing, for example, the prolactinoma care, because if you are taking cabergoline, you you can go to school, you can go to work, and maybe you don't feel well. But if you do an intervention, maybe in the end it will be cure without treatment. But there is a period of recovery after intervention. And if you aim for the best, you want to make this time as short as possible. Hospital stay, and it's of course expensive. So we did a project to try to shorten the period of admission. And I'm not sure how your situation is in Indonesia, but for the less complex pituitary surgeries, we usually send patients home at day 2, day 3 after surgery. And then we developed a care path in which patients, there is a case manager, it's a nurse specialist, and there's a daily contact by eHealth to check on these post-operative patients. And so we are continuously in contact with the early postoperative patients in a home situation, and if possible, then and it's mainly the fluid balance, of course, that is important, is checked, and as soon as there are derangements, we can act. And so we were able with this care path to shorten the time of hospitalization, and of course that is a economic benefit, but it's also better for the patients, and it helped us to increase capacity. So of course the complications of surgery were very critical about that, and one of the things, of course, that's also important is the nasal morbidity after surgery, and that's on the one hand not on the list, but on the other hand it's very important to patients. And then the third tier is to look at the recurrences, etc. And that's a difficult thing in pituitary care because you really need to have a long, do you say long breath? You need to look long to be really sure that you operated without recurrence. And now that's I think it's very important because we have been changing our minds on recurrence surgeries, because in the end we think that it's better to have like surgery in a few steps instead of damaging the pituitary glands. And that's that's where we are. That, for example, in Cushing's disease, you in the guidelines you do exploration, and then you do a vasectomy, and then you can consider to take out the adrenals or to do a total cellular clean out. And that is an intervention that we more or less stopped doing unless it's really, really, really necessary. So we accept the approach of doing a surgery and do an exploration, and then stop if you're satisfied as a surgeon, and accept that but there are a lot of patients that need a reoperation for Cushing. And with endoscopy, the reoperations are doing quite good. So we are happy with that. But that's an approach that you really need to be critical about, because of course it's very expensive to do a second surgery. It's very invasive for the patients. So you need to weigh again the long-term outcome of the approach with repeat surgeries as necessary via the versus the one intervention, and maybe accept hypopituitarism of the rest of your life. So that's an important thought, and I don't know the answer yet. If you have talk about long-term outcome of patients, of course, it's the first intervention, but it's also the care of the aftermath. So the care of long-term complications, the care of the self-management, improving the self-management, understanding adrenal crisis, acting on adrenal crisis, etc. So there is a full team for chronic healthcare. And I think that's one of the problems we are facing at the moment. That, well, for my idea, I think it's like, well, many pituitary patients require like 2-3 years to be really, to understand what kind of disease they have, to really understand how they can act on their self-management, how hormones need to be titrated to be optimal, to get some, well, acceptation of the disease, etc. And if you are a pituitary center of excellence, it's difficult because your patient numbers are growing and growing, and the doctors who are treating the cases are not growing. And then, especially if you have a team with nurse, the care that you can deliver as a pituitary center of excellence is so much better than care in the neighborhood of patients. And I think that's really a challenge, because if there's not a wish or a opportunity to travel, which will probably also be the case in your situation, then you need to refer back. But if patients, well, are able to choose, then usually there is a big gap between the endocrinologist in a local center with limited experience and the full team. And then I think the nurses are very important to give the patient the idea that they are well understood, etc., and they are helped with their unmet needs. So I think that is a discussion that we are facing. How can we organize this network care? How can we collaborate with local physicians and meet the standards that we would like to give to patients in the aftermath of treatments? So I'm very interested to find out how your thoughts are about that. Then I need to. I do not see my slides move. Yes. I think this is one of the things that I think is very, very, very important in pituitary care, because it's not about the endocrine glands, but it's about the patients, and it's about the vision, and it's about and so every patient is different. And well, I'm interested to find out. You have your list of diagnoses, and I think that's the way that we started. But in the end, it's also about there's always a combination of many situations. So it's acromegaly plus hypopituitarism plus vision issues, and you need to act on all those parameters. So important to realize that. Then we have maybe the idea of the holistic part of the patients, which is, we can't oversee everything. We do not need to oversee everything, but we have to realize that it's so difficult. So it is not only the patients and the disease, but it's the disease is very heterogeneous, but then the symptom and the comorbidity of patients is also very heterogeneous. So some patients have a very severe tumor with high levels, but no complaints whatsoever. And other cases have very little overproduction and feel really invalidated. And there, if you go to the psychologically literature, there's the Wilson and Cleary model that tries to summarize that by a conceptual model. And then it's important to realize that personality is of importance, the coping strategies, how patient act in their environments, how is their their economic support, etc., etc., and it all affects outcome in the end. So if you want to address patient-reported outcome and quality of life, it's important to understand this system, and it's not only the care that you deliver at your pituitary clinic. And I think it's very important that this concept is so difficult, and that a quality of life measurement is not everything. Well, I want to switch to the slides. These are measurements that we try to do in cross-sectional data on quality of life. And then, of course, we really know that active disease is associated with very impaired quality of life, but also treated disease is still less perfect than normal situation, or patient from the same surrounding without a pituitary condition. So there's a lot to improve. And I already talked about the questionnaire that we made, and I think this is a good disease-specific list, and generic quality of life measurements are not good enough to understand the issues that are faced by pituitary patients. So usually they are able to climb a stair, but they are not able to climb 3 stairs, for example. So the generic quality of life is then less sensitive, not enough sensitive to detect the limitations that the patients face. And this list was developed together with patients. So they were together in a discussion room in a focus group, and they rated all their issues. We are working with this in the patient clinic now. So they fill the questionnaire prior to the consultation. And then the nurse is discussing their outcome. And sometimes we get a very bad list. And then if you discuss about it, patients are feeling fine, but are recognizing their issues. And sometimes they are underreporting. So I would say that filling the list is not the truth. You really need to use it as a way to discuss issues that are important to patients. And I think it's important that we found out that, and of course, when you're caring for patients, we try to measure it, that fatigue, etc., and issues with work and neurocognitive complaints are very, very, very important in the issues. Sexuality is an important thing. Relational things are important. Sleep problems are important. And we split the list in the bothers and the need for support. And I think here it's important that we can also adjust our care, because if you have a bother, you can help, but sometimes you cannot normalize it. But if patient has their care for an issue, and they understand their issue and they have learned to cope with it, then usually the need for support decreases and the quality of life improves, even when the bother is still there. So that's how we get it in our electronic patient records. We are very proud of it, that we are managing to do that. But it's still, you don't have normal values. You have the interpretation of the patient. It's really a struggle how to use it. So I think we are pioneers still. I think the world is pioneer here. I want to skip this. So I was also telling that I think in the end, the outcome of intervention are very important, because you use that to choose between best treatments. And this is the publication of the outcome data that we try to address in our care path. That's something about it. And I don't think it's about the numbers, but it's about the initiative to report your data, to know your data, and to understand your data. And when you're doing registries, you want to have data from the full group, which is very important for the system. But you also need data for the patient, like the patient in your combination clinic. So you have to find a way to get both numbers of the full group, the total group, and to have the data split for your own case. So I think that's also one of the unmet needs that we are really hard trying. How can we get from the system? And we are not there yet, so it's a work in progress. The numbers that are important for the patients, that is in your combined clinic at that moment. So I hope that you recognize this challenge. And of course, we have the retrospective data, and we have more or less idea on your own interventions, but to really adjust it to the individual, that's really a challenge. And I think that's one of the things that I'm working on at the moment. And it's on the one hand, more or less about complications, which I think are very important. It's also about efficacy, and it's about quality of life. So I think it's Dickie, I can continue for ages, of course, but maybe you want to finalize and have discussion, or what do you want?
You can still have another 5 to 10 minutes if you like. Otherwise, we can also go to discussion.
Yeah. Maybe I would like to go on for the discussion. I can show you this slide. It's a little bit difficult, but it's one way that we try to in a rare disease with low numbers, that we try to conclude whether we are happy with the intervention or not. So depending on the goal of surgery, I think the goal of treatment, that's the new idea. We try to integrate the outcomes that we measure in, we are perfectly happy, there was a remission without complication. We are fully unhappy, so there is a poor outcome with no remission, and there is a ongoing complication. And there are two intermediate categories that depend on the disease, whether you're okay with it or not. And one is that no remission, but there's no complication, then you can move on with the next intervention or treatment. And there is remission, but there is a complication, and that is of course a pity, because a complication is a complication, but sometimes remission is so important. And then I, for example, refer to craniopharyngioma or Cushing's disease, that the disease is so severe that you sometimes need to accept pituitary function loss. So this is a way that you can integrate the big list of outcomes that are important. And the idea is that you can, for example, combine improvement of vision, which is a goal for one patient, and endocrine remission, which is important for other patients. And so you can get like a composite outcome for the system. So if you want to do how good is our surgery, then you can use this kind of methods to get an overview of evaluation per intervention. And what we do in our team is that we have like a system that we discuss all outcomes at 6 weeks postoperative and 6 months postoperative. The 6 months postoperative is important in our registry. That's there's a quality registry, national quality registry in neurosurgery. And so we need to record the 6-month data in that registry. But we now made the step that we discuss all outcomes at 6 months. So the team is aware of what we are doing with the patients. And so then we discuss what was the outcome, but also did we expect the outcome, and did we, and if there's a discrepancy, do we understand why? And could we improve it in the next time? So that's, I think, one of the important steps that we made in the multidisciplinary team, that we try to step back and evaluate what we have been doing. And it takes some time, but it learns you so much that we think it's worth doing it. And for example, sometimes it's the radiology that could have been better preoperative, and maybe you had made another decision to do surgery or not. And sometimes it's the history taking of the patient, that maybe you had to realize that in this case, things could have been more difficult, for example. And I think that is an important step in quality improving as well. And sometimes, for example, in a prolactinoma case, we have, for example, a psychiatric patient who does not tolerate drugs. And then we do surgery if there are good perspectives for total resection. But for example, sometimes you have the idea that you can, cure the psychiatric disease, but of course we can't guarantee that. And that's something in the evaluation that we really understand, that we can treat for the side effects, but we can't expect the psychiatry to normalize. And it's important that we know that when we are, in the next patient, trying to decide. And of course, if you know, it's 50% chance that psychiatric symptoms are going to improve, and we can take the risk, but we know it's only 50% improvement, for example. So that's the way we have start thinking. And so we now present our results for this meeting as very, very, very simple. The white is the good one, the black is the one that are really undesired, and the others are intermediate, and you need to discuss whether it was good enough or not. I'm going to skip all this. Maybe good to finalize here. This is the care path that we wrote down of how we try to organize it. And this is probably the way you have been thinking as well. And it's a work in progress, and you have to be flexible in pituitary case, to my view, because many times it's a little bit different than the standard patient. One other thing I would like to say about registry is that we have a registry in our own center. So for our own results, and it's very detailed. We have the National Quality Registry of Neurosurgery, which is not that detailed, but it's an approach that you can compare or understand national patterns. And then we have the European Reference Network. I think that's important as well. That's a new development. And that network has, I think, the best registry there is for pituitary cases, because there is it's a 3-step process. The first step is very simple. It's only a registry. This is a patient with a pituitary condition, and this is the condition dot. The second step is, and you can only fill that. The next step is that you can fill some basic feature of the patient, so very critical, very concise core registry. And then there is a detailed registry of patients of interest. And I think this approach can really help to make it feasible. and to make it doable, because it's really hard to record registries and fill registries and continue to fill registries. So I hope to share ideas. Thank you so much for your attention.
Yeah, thank you very much, Professor Biermasz, a very insightful sharing of experience, especially on the approach of value-based healthcare on the pituitary care in the Netherlands. I hope this should be a lot of questions from the audience. I would like to invite all the audience to ask to Professor Biermasz. You can either write down your questions in the chat box, or you could also raise hand. I would like to have you speak directly to Professor Biermasz. Okay, while waiting for the questions to arrive, I received one question from Dr. Johannes. He's an endocrinologist working on a private hospital. He's asking about the prolactinoma, about your the experience in your center on treating younger female patient with microprolactinoma. How about the preparation for pregnancy and so on?
Okay, now prolactinoma is of course a disease that is there in young females. It's the majority of cases, and the medical treatment is of course excellent. So usually when you start treatment, the tumor shrinks and the prolactin normalized, the cycle comes back, and patients can get pregnant. And in a small prolactinoma, it's not needed to do a scan prior to getting pregnant. And in a larger prolactinoma, well, the bigger microprolactinomas and the smaller macroadenomas, I would like to see that the tumor shrinks. Because if that's the case, then usually I stop the drug as soon as a patient is pregnant. And if there is not shrinkage and it's, meaningful adenoma, sometimes you have to wait for a while. But if it's a tumor that is closely related to the chiasm and it doesn't shrink in time, then usually I advise to do surgery prior to getting pregnant. But it's of course a very individual decision, because if it's possible, you don't want to operate. But if you are in doubt and there is not that much space between the tumor and the chiasm and it doesn't shrink nicely, then well, probably it's better to do surgery if you can. But again, it's very important that you do not induce pituitary failure, because then spontaneous pregnancy is not possible anymore. Sometimes you have to restart in pregnancy when there's headache, and sometimes there's some growth. But usually when you continue with drugs in pregnancy and we consider that safe, then the tumor becomes controlled again. And it's I have good experiences with outcomes of pregnancies, to be honest.
Okay, thank you, Professor Biermasz. I saw Farid. Dr. Farid, you would like to ask questions? Please.
Yes, thank you, Professor Biermasz, for your very nice talk and insightful. I have very good new perspective on the pituitary care before this. Yes, it's really interesting. I have several questions actually. One is regarding the psychosocial support that you mentioned before. I don't know whether you have certain teams regarding with this psychosocial support, but it consists of psycholog or psychiatrist, and is it one permanent team or just you consult once at a time? That's my first questions. And the other question is regarding the care manager of because for the value-based healthcare for this pituitary care, you mentioned about the care manager. Is it a nurse or other than nurse that dedicated for this as a care manager? And I suppose you have to train them to be a good care manager because they have to know a lot about pituitary condition. How long do you take them to, or do you have to train them to have them as a good care manager? And that's my second question. And I think the last one is more clinical part. It's always on debate. It's regarding the corticosteroid protocol for a person that has a surgical pituitary surgical operation on the pituitary. I think as experience in your centers. Thank you.
So there's a lot of questions. Highly clinically relevant, because it is exactly the journey that we made and what was so difficult. So your first question was about the
psychosocial support for these patients.
So I think it's not really developed like that, but the first step is to be aware as a team and to have that there are psychosocial consequences. I think the second step is to have a situation that the nurse, and of course the doctors always, but the nurse is specifically addressing the psychosocial situation. Then with help of this, we use our own developed questionnaire, we can address the unmet needs for psychosocial support. And that's of course together with the talk in the outpatient clinic about it, or the question of the patient about it. And then sometimes it's enough when the nurse addresses the issue. Sometimes it's needed to do more. And then we can go to we have some options. We have a group training. It's called the Psychosocial Education Program. And usually that's together with 8 other patients with a pituitary condition. It's developed for chronic disease, but we made it more specific because patients need to recognize their issues. So twice a year we do a group with 8 patients, and it's called PEP training. And then they get 8 sessions of 1.5 hours dedicated to psychosocial training, and it's fatigue management, it's transfer of information, it's how to use the healthcare system effectively. So which doctor do I ask what question? Help to be with how do we interact with partners? How do I interact on work, etc., etc. And within this training, of course, they have a lot of patient-to-patient interaction. And for example, they exchange ideas about stress management of adrenal insufficiency, etc., etc. And they recognize each other's problems. So I think that's the basic training. And sometimes patients need individual psychological support. And it's always difficult because it's not always reimbursed, but I think it's very important to help them. And it's always difficult when in the treatment trajectory that's needed. So if they're very young, sometimes it's not needed at the moment of diagnosis or early treatment, but it's needed later on. And one of the interesting questions that are always there is from who would I be without hormone excess syndrome? And there are many issues with sermonage, so the too little energy and too much to do, and how do I organize my life with my limitations, etc., etc. But also the psychological part of being a little bit different person with the hormone disease. And of course, the adrenal insufficiency reacts on not being in sync with yourself. So that's important to realize that, especially the patients that are psychiatric or psychological not well, that they usually have more issues with hydrocortisone replacements, is my experience. So the nurse is the other thing. That's when we started the project, it was a Ph.D. student, so a physician who cared for the early discharge projects and the context with the home situation. And I think it's important because it's it's really critical that you are well trained. And I was it was very strict supervision for me and the surgeon, because it's multidisciplinary. It's not only the endocrine complications, also the neurosurgical complications. And then when we had the feeling that we were experienced, we were able to educate a nurse. And it's a nurse specialist, so she has a specific training to become a nurse specialist, which is generic. And there is, of course, a work floor training that is, well, to my view, 2 years or so, to be really, really well focused. And of course, the difference between a nurse and a doctor is that the nurse has a very tiny training in one aspect to become really specialist, and she's better than the general physician in this tiny field. But of course, the physician has always the broader view and more pathophysiological basis to understand the exceptions, etc. But for getting a good dedicated pituitary nurse, you need 2 years of training, and it's intensive training. So it takes a lot of energy to teach somebody. But in the end, you don't want to have a fellow that is leaving every year, and then you have to start over again every year. And that's I think, the big advantage of a dedicated nurse that is really dedicated to the patients, etc., etc. There was a third question about hydrocortisone.
Yes, regarding the steroid protocol for the pituitary surgery.
Well, there's no consensus. There are centers that do not use coverage. There are centers who give very high doses, and we are in the middle. So we give like 50 milligrams of hydrocortisone IV during the surgery, and then we do a double dose of oral the day after the surgery. Then we do a normal physiological dose the second day after the surgery, and then we measure cortisol, and if it's good, we stop. And if it's in the gray zone, we continue, or we stop, but we give a prescription to home. So that's more or less how we are doing it, and it's work fine. We get very little admissions for adrenal insufficiency. And I think one issue, which I think is very important, is when you have like a diabetes insipidus or a postoperative hyponatremia, you can't evaluate the cortisol axis. So then we always continue with hydrocortisone until stable, and then we move on to testing. But we do not do dynamic testing anymore. So we rely on a morning cortisol in a stable situation. And we do the dynamic testing later on if patients are not feeling well.
Thank you so much for the answers.
Okay, thank you, Professor Biermasz. Also Dr. Farid for the next question and also the answers. I would also to invite other questions as well. So we have quite a lot of diverse attendance actually, Professor Biermasz, from across Indonesia as well as from across hospital as well. I see a raised hand by Dr. Andrian. Could you please ask your question, Dr. Andrian?
Yeah. Good afternoon, Prof. from Indonesia. My name is Andrian. Currently, I'm doing residency. Just wondering, in your patient journey for the pituitary patient, so at which point the patient is referred to the tertiary or the main central hospital? Because here we found that sometimes patient comes directly, but it's also because it's a referral system, it's need to be checked from the primary and the secondary healthcare. So I'm not sure in Netherlands or whether it's when you already suspect that it is a pituitary function disorder, do you directly refer to the central hospital, or do you actually go through each and every test first, and when it's sure that it's a pituitary function, then you go for the central hospital. And my second question is at the other end of the journey. So after we finish, so when do you refer back to the secondary or the primary care, or do you actually keep the patient in the central care, hospital care? Thank you.
Please, Professor Biermasz.
Yeah, I think there are a lot of stories, and I think we need to make still steps in organizing this. And one of the issues in the first diagnosis is that it's sometimes patients are within the endocrinology department, and then usually it's well quite good, sophisticated how things go, because the endocrinologists have a focus, they know what they're doing, they know what they can do themselves, and when they need to refer to a center. And the reasons to refer to center is, of course, well, question marks about the diagnosis, or urgency for intervention, or well, shared decision making. And the one primary or secondary endocrinologist has more affinity with pituitary conditions and can do more themselves, and others don't know, and then they refer earlier. And sometimes it's depending on the patient situation. But I think when I like to have like very good interaction, because for example, if there is hemianopia, for example, you want, as a surgical center, you want to know that it's announced, for example. So we always hope that patient that doctors contact us to be able to already schedule surgery, for example. So it's important that there are short lines and good connection between centers. And of course, you also have the multidisciplinary team. I think we are going to a situation that there is well, weekly or monthly meeting with the local partners to discuss cases. And of course, if you can do that, then more patients can stay in their own region, and we can give virtual advice. And if that's not well organized, and you don't know the doctors very well, the network is not functioning, then of course you need to refer to get good advice, for example. We still have some difficulties to exchange photos, for example. And photos and MRI scans are very critical for judging what you can do. I think a very important example, for example, is those prolactinoma cases that, of course, we always start treatment with medication. And as a local partner, you won't discuss surgery unless you're very unsatisfied with the drug, and it's really like a absolute contraindication to treat any further. But if you are in a center, you can have this shared decision making. What is possible? What can we do? What are the alternatives? And of course, well, it doesn't really matter. You can have both worlds, of course, but there is, of course, an optimum in discussing cases and having the opportunity to do the shared decision making. And I think this shared decision making is really, well, you need your pituitary center for that, because that can't be organized locally. We have no restrictions in referring, so it's quite easy. You can easily have a second opinion. You can refer back and forth, etc., etc. Probably that's more difficult in Indonesia. I'm not sure, but we need to think about that. Referring back is also an issue. I already told that in my presentation, because sometimes patients are really unhappy with the diagnostic trajectory because it took a while to make the diagnosis. And then, well, when patients are in the pituitary center, they don't want to go back. And that's really difficult how we should manage that, because in the end they need to go back, because otherwise there is just no capacity anymore. And there are also cases that have a good, well, that's the ideal situation, but that there's a moment of wait and see and making a good patient-doctor relationship with your local physician, and then there is a moment of an intervention, and then after the intervention you already know your own local doctor. But that's the difficult thing, I think, in pituitary, that there's usually like an urgent referral in the beginning, and then you're not really connected to your local physician. I don't know if you recognize that.
Yeah, we here in Indonesia also have the problem with the referral, Professor Biermasz, because yeah, of course, we don't have the same facility across Indonesia, especially on the lab exam, but also on the radiology imaging as well. That's why sometimes they have difficulty. But the idea of multidisciplinary approach, while not sending the patients first, I mean, like this first discussion, and then if needed, you can then send the patients to the other city. That would be a nice options, because otherwise you would then need to send people across Indonesia, for example, from Sumatra to Italy to Java, from Sulawesi to Java, and then the patient need to stay for a couple of months in other cities as well. So I think the idea of with like this online meeting with multidisciplinary approach would be good options.
Yeah, and I think COVID has made a lot possible that wasn't possible prior to COVID. And I think the multidisciplinary care for rare conditions can improve a lot by e-health and web discussions, etc., etc. So I'm enthusiastic about this way of collaboration.
Yeah, a lot of cases in Indonesia, we saw the cases on the late stage. For example, we easily can get like people with a giant micro prolactinoma with more than 4 centimeters already destruction to the other structures as well. So it's quite difficult. It's quite astonishing to see the result in your center. You've got a lot of people achieving what you want, right? Remission of a nice quality of life. In some it's not. It's almost difficult to achieve those because yeah, most cases came on the late stage because of the lack of resources and so on.
Yeah, but still we get incredible tumors, even in a system which is quite facilitated with every facilities, etc. We still get those huge prolactinomas with huge invasion or acromegalic patients, and but they sometimes develop without clear complaints, and it's always a challenge to try to find earlier, isn't it?
Yeah, it's quite challenging. Okay, Andrian, do you have any other questions?
No, thank you, doctors. Because I think recently we had a few cases that we actually discussed, doc, that we did the discussion in the hospital, but then we need to think about, because the patient need to go back to other city as well.
Excuse me?
Oh, no, Prof. Because last time me and Dr. Diki had patient that need to go back to other city after the treatment. So we are just wondering, when should we refer back to the patient after the treatment back to their original city?
Yeah, well, I think it's very regional dependent what is possible. And usually when there is a successful surgery, you can refer back quite quick, like after 3, 4, 5 months. And if there's another intervention needed, for example, in larger tumors in acromegaly or persistent Cushing's disease, of course, you usually keep patients in your control. And sometimes there's a very difficult tumor remnants, then we prefer to keep them, because the scans are very critical, in a center that can make good MRI scans. But for the endocrine care, referring back is fine well, usually early after surgery. And especially if there's a long distance patients, we send, well, we send back immediately, and we are there for the backup, for example. And then you always know the patient if you have treated it. So it's very easy to have like a, well, some sharing of ideas if it's needed.
Okay, thank you, Professor Biermasz. Thank you, Dr. Andrea.
In my experience, there's a lot of, it's very individual. So probably you recognize that there are so many circumstances. I think it's quite hard, or I am not able to really make like very easy guidelines that are always applicable for sending back and forth, etc.
Thank you. We'll be behind our schedule, but maybe I would like to invite maybe another 1 or 2 questions. Professor Sarwono, Professor Sidartawan, would you like to ask some questions?
Yeah, okay.
Yeah, Professor Sidartawan Sugondo, please.
Okay, Professor Biermasz, thank you for your nice lecture. First, I want to introduce myself first. I had my pituitary training in Vrije Universiteit under Professor Ed van der Veen.
Ed van der Veen.
In the 1988. It was a long time ago. Yeah,
I remember him.
You remember?
Yeah.
Yes, I was in the 1988 at the VU, yeah, Vrije Universiteit, and we had, yeah, I had my pituitary training party there. I was just wondering, you mentioned that the Leiden University, you said your center is more a surgery center. Yeah, the endocrinology or intervention is preparing, but the surgeons are the ones who the better they do, the better results. Yeah, this before they being an expert, they have to do more and more. But how many do you think? How many operations do they need? Because the more precise they are, the less complications and the less emissions it is. Yeah. We can prepare it very well, but if the surgeon is doing not well, then we have to suffer, or the patient has to suffer. We have to do more work.
Yeah.
Yeah. How many patients do they need before? Because as a new surgeon, neurosurgeon, of course you are, it's different. Okay, thank you for your comment.
Yeah, I think it's an interesting thought. I think, of course, they need their technical skills, and that is, of course, a combination of talent and doing a lot. And I think they are best when they have done like thousands of pituitary surgeries. But well, they need to be trained as well. And in our center, they operate with 2 neurosurgeons. So they operate together, and they usually it's ENT plus neurosurgeon, and in our case, it's a skull-based neurosurgeon plus another skull-based neurosurgeon. So they do the nose themselves, and that makes it very interesting because the pituitary parts, they are together, and during surgery they have conversation about what they should do, which approach they would take, and the way they work together helps them to improve themselves because they're always checking with each other what is the best. And for example, now last years they developed the surgery in the cavernous sinus, and that's, of course, there was a forbidden area, but with more experience, you feel more confident to go in that area. And it's important for endocrinologists to know because that gives more perspective for some cases with lateral disease, for example. But you also need to know their limits. But it's interesting because So they operate together. It's a team of 3. And 5 years ago, we did 50 surgeries a year. And now we do 170. So with the focus, with the expert center, with the the creating capacity with short admission, we increased our service to 170 surgeries a year, and that's a lot. And we, for example, we do 3 a day now, and then so they get better via their their routine. But they always tell us that they also are critically dependent on the way we discuss the indication. So the good surgical outcome is also dependent on the way the endocrinologist and the neurosurgeon have the preoperative conversation, to the expectations, the goals, the options, the alternatives, etc., etc. So that's a very, very critical aspect that we can help them improving their outcomes. And the other thing that is very critically dependent is the knowledge of the outcome. And that's, of course, in a neurosurgical center that they work more as a neurosurgical department, then they usually are not well informed about the outcome of patients, because we know that patients are suffering and they're happy with the outcome. And it's very important that we create the way of feedback. So I really believe in the feedback, and so I also believe in the system that we have with the morning conversation within our team. So every Wednesday morning at 8:15, we have a moment that with the team we discuss all surgeries that are scheduled, all surgeries that have been done that week, and all complications that we can identify after 2 weeks, and all problems. So that's every week. And then at 6 weeks, we have a moment of feedback together. And then at 6 months, we have a feedback with the neurosurgeon about the long-term, the 6-month outcome. And then sometimes we think we are totally happy, but the patient is not. And we think that's also important information. And that's the way we change our thinking. So it's about preoperative planning and decision making, having the surgery, the surgical team discussing their own doing, and the intraoperative discussion, and the postoperative feedback.
Okay, thank you very much. Thank you.
And you have to be very proud of surgeons and help them performing best, I think. And but it's if I would not have a good surgeon, I would not send so many patients to surgery.
Yes.
As soon as a medical alternative is better, I would do it myself, for example.
Okay, thank you very much.
Thank you, Professor Sidartawan, and thank you, Professor Biermasz. Yeah, I would love to have a discussion, still a long way to go, but unfortunately we have already almost 20 minutes behind the schedule. So yeah, past the schedule. So I hope in the next, maybe if possible, if you don't mind, maybe we can also invite you if you have more on discussion later on clinical cases, so we can share insight and so on, hopefully. I would like also to thank you for a very nice sharing of experience from you from the Netherlands, as well as some clinical insight and aspect of the importance of value-based medicine and the pituitary care, as well as the multidisciplinary approach. It's very nice that you mentioned about the weekly meeting, as well as from the neurosurgeon, also the endocrinologist, sharing their thought on the patients and the outcome. I think we can learn a lot from that, and we can try here in Indonesia trying to develop such a system. And we already at the end of our session today. Thank you for all of the attendants who will come here and this today. Also, thank you, dear professors, also Professor Suastika from the Indonesian Institute of Endocrinology, Professor Hegar, also Julie, Professor Sarwono, Professor Jartawan, and I saw a lot of experts as well across Indonesia, across private and public hospital. Hopefully, what we discussed today can also give us insight here in Asia about developing a better pituitary care in the future, despite all the constraints that we have. And hopefully we can later on in the future also have a further collaboration within Indonesian Institute of Endocrinology, with Leiden, of course, and to have shared thought on several cases that we can discuss later on in another time. Okay, thank you very much, Professor Biermasz. Thank you very much also.
Thank you again for the information, for the invitation.
Thank you.
Thank you.
Thank you, Professor Biermasz.
Thank you.